Hello, everybody. Happy to have you all with us for Grand Rounds today, and couldn't be happier to have our special guest today, Dr. Girish Nadkarni, who, as many of you know, is the Fishberg Professor in Medicine at the Icahn School of Medicine, the Chief of the Division of Data-Driven and Digital Medicine, and the Director of the Charles Bronfman Institute of Personalized Medicine. He received his training in mathematics before completing his medical degree at one of the top-ranked medical college in India. Did a master's in public health at Johns Hopkins, some other training at Hopkins, and then has been a resident and fellow and a research fellow here at Mount Sinai. He's authored over 300 peer-reviewed articles. He's won numerous awards, and we couldn't be happier to have him with us today talking about optimizing care for patients with type 2 diabetes and chronic kidney disease. Dr. Nadkarni, take it away.
Thank you, Dr. Weissman. That was a very kind introduction. I'm not sure I deserve that, but I'll take it. Today I'm going to be talking about optimizing care for patients with type 2 diabetes and chronic kidney disease, or diabetic kidney disease, DKD. So in addition to my other roles, I'm also a nephrologist, I'll be predominantly talking about how a product that we developed around risk stratification and kidney disease and diabetic kidney disease, and then formed a company around it, is now being used. So I do have a conflict of interest here because I'm one of the scientific co-founders of this company called as Reliably, which commercialized the product, and I'll be talking about the product Kidney Intellects today. These are my other disclosures. Please stop me, interrupt me at any time if you have questions, and I'll make this interactive rather than me drone on for the next hour or so. So this doesn't really need to be explained. As most of you know, diabetes is the leading cause of dialysis, end-stage kidney disease, and kidney transplant in the United States. And the numbers are kind of staggering, right? So every 24 hours, patients with 170 people with diabetes begin treatment for kidney failure. I don't know why this is not rendering, but 40% of all of the patients with kidney failure have diabetes. So diabetes is a predominant cause. Now, it's anticipated that end-stage kidney disease is probably going to rise further because of changes in obesity and population trends, both of which are linked to type 2 diabetes and to the progression of kidney disease. So the prevalence is sort of anticipated to go up further and further. And it's been going up pretty consistently since the 1980s, since we have like reliable data. And the projected incidence is expected to hit around 3,500 patients per million people. And this is a big healthcare as well as an economic problem because of the fact that in spite of changes in treatment modalities, the inexorable rise of end-stage kidney disease hasn't really changed. And it becomes a further problem because of the link between cardiovascular disease and chronic kidney disease. Chronic kidney disease is a disease multiplier for cardiovascular disease. So this shows this overlap between cardiovascular disease, type 2 diabetes, and chronic kidney disease. And this shows the proportion of patients with underlying cardiovascular disease as it goes with the increasing CKD stages. And progression of CKD is also associated with an exponential increase in adverse cardiovascular events and poor outcomes. So this graph shows the increase in heart failure and cardiovascular events with decreasing estimated glomerular filtration rate. If you have a reference range, or if you have decreasing GFR, then you can see that the proportion, the event rate per 100 person years goes up exponentially with the decreasing GFR. Same thing for hospitalization, and same thing, more importantly, for death for any cause. The differential between normal GFR and extremely decreased GFR is 15-fold at this point of time. And patients on type 2 dialysis, diabetic patients on dialysis have extremely, extremely poor survival, right? So I used to attend the dialysis shift, and this is a lot of personal experience along with empirical data that the mortality rate in this patients is extremely, extremely high. So around a quarter of patients have mortality every year if you go on dialysis. And this is exemplified by this Kaplan-Meier curve, which shows over 8 years, the mortality of patients with dialysis is much, much higher than the patients who do not have dialysis. And survival with dialysis and diabetes is much lower than several cancers, right? So this is a graph showing the 5-year survival of several cancers. And as you can see, type 2 dialysis has lower survival than several cancers, including leukemia, prostate cancer, colorectal cancer. And this is especially accentuated if you have diabetes on top of dialysis as well. The only cancers that are sort of have lower survival include pancreatic, lung, esophageal, and stomach cancer. And along with being a major healthcare and mortality problem, this is further accentuated by the fact that patients who have chronic kidney disease don't really receive appropriate healthcare, right? So only 32 of patients starting long-term dialysis were under the care of nephrologists for a year. This is from the USRDS, which is the United States Renal Disease Registry. And this shows how many patients have kidney disease care before they actually crash into dialysis, right? So only 19% of patients have kidney disease care for the 6 to 12 months prior, 14% have patients, but 21% don't really have any kidney disease care. And the result of that is that 2/3 of patients have late engagement with a kidney disease specialist. So they basically crash start dialysis in the hospital. I mean, as internal medicine physicians, all have seen this, right? Patient with end-stage kidney disease, they come into the hospital. Most of the ER, potassiums are high, blood pressures are super high, and they haven't seen a nephrologist or haven't any kidney disease care prior to this, and they basically quote unquote crash start into dialysis. And there's what we call as a lot of inertia in early CKD, and CKD is measured in stage 1 to 3 by PCP. So this is data from NHANES, which is a large national representative registry, which shows what proportion of patients with CKD actually have awareness of their own disease. And there was another large study called as a CKD detection study, which showed that in stage 3, only around 18% of patients who have any knowledge of the fact that they have kidney disease. And this is a problem because kidney disease is predominantly a silent disease. Kidneys don't cough. So until you reach the later stages of kidney disease, you don't really have any symptoms. So it's predominantly a very silent disease. This is worse at a national level when only around 8% of patients in stage 3 have any knowledge of their kidney disease. And this has led to a further therapeutic inertia where there's inadequate treatment of chronic kidney disease by physicians. So things that you can do to slow kidney disease: decreasing blood pressure, decreasing HbA1c, starting on a RAS blocker, starting on a statin, and starting predominantly on SGLT2 inhibitors, which are not so novel drugs, but have shown to have significant kidney and cardiovascular benefits. The rates are very, very low in stage 3 kidney disease, right? Only around 50% of patients have the blood pressure controlled. 60% of patients have the hemoglobin A1c controlled. 35% or so of patients are on a RAS inhibitor. 30% of patients are on a statin, and less than 10% of patients are on the SGLT2 inhibitor. And this is because of the fact that kidney disease is largely asymptomatic until the later stages, right? So again, sort of preaching to the choir, and a lot of you know this, kidney disease can be divided into 5 stages based upon the GFR, right? And based upon the proportion of kidney function remaining. Stage 2 to stage 3, there's predominantly no symptoms, but because of the fact that 90% of population are in the stages, there's a big chance to make a difference. And you only start getting symptoms in stage 4 and stage 5. And there's a lot of symptoms that can occur in stage 5. Another portion of my research sort of deals with patient-centered outcomes. And the symptoms that can occur in stage 5 are, as you've seen in a clinical practice a lot, you can get nausea, vomiting, tiredness, headaches, itching, swelling, leg swelling, and a lot of the symptoms are essentially, unbearable. And that's why dialysis doesn't really make them better. You have other symptoms associated with dialysis. So I've hoped I've convinced you at this point of time that, a lot of kidney disease is asymptomatic. It's in early stages. There's no symptoms in the earlier stage, and that's what has contributed to therapeutic inertia. But the problem is a lot of patients with diabetic kidney disease are in those early stages of kidney disease, and that's why you need to do something in those early stages. And that brings me to the need for risk stratification in chronic kidney disease, especially in the early stages, right? So this is a figure from the ADA 2002 Cardiovascular Disease and Risk Management Standards of Medical Care. And this has been one of the pillars for other diseases like heart failure and cardiovascular diseases, where, instead of starting one thing at a particular point of time, you do goal-directed management therapy and start a lot of things at the same time. Obviously, the bedrock of this, the foundation of this is lifestyle modification and diabetes education. But the pillars of this include glycemic management, blood pressure management, lipid management using statins, and agents with cardiovascular and kidney benefit, including SGLT2 inhibitors. And this was incorporated into the guidelines for diabetes care in type 2 diabetes by ADA, which says that you may need to start off with SGLT2 inhibitors or GLP-1 agonist in patients who are increased risk of cardiovascular events and CKD progression. And therapies to reduce CKD progression and reduce heart failure risk are now present, right? So obviously the mainstay of treatment was ACE inhibitors and ARBs. A lot of clinical trials showed reduction in CKD progression and in heart failure hospitalization. But now there are newer drugs which basically do this much better. So SGLT2 inhibitors, there's a huge amount of evidence now showing that it works in patients with type 2 diabetes and chronic kidney disease. It works in patients with chronic kidney disease even without type 2 diabetes, as shown by EMPA-KIDNEY and DAPA-CKD. And new non-steroidal mineralocorticoid receptor agonists, including finerenone, are now present, which reduce CKD progression by 20%, reduce heart failure hospitalization by 22%. And there's a new category of drugs coming called as endothelin receptor antagonist. So the clinical trial SONAR showed decrease around 30% in CKD progression. Didn't really show effects on heart failure hospitalization. In fact, there was a slight tend towards harm for heart failure hospitalizations, with the confidence interval here crosses 1, but there's maybe a tendency towards harm. But it can be said that this is a large sort of network collaborative meta-analysis which showed the impact of diabetes on the effect of sodium glucose SGLT2 inhibitors, which showed improved outcomes for kidney disease, cardiovascular risk of death or hospitalization. There was a slight tendency towards ketoacidosis and lower limb amputation, but this was predominantly in patients who had existing wounds on their legs. And heart failure outcomes were even better than for chronic kidney disease outcomes, right? And the accompanying editorial basically said that right now, SGLT2 inhibitors should be used as a foundational therapy for chronic kidney disease, and the time is for implementation of these rather than for hesitation. So, but as I showed in earlier slide, the proportion of patients, eligible patients who receive SGLT2 inhibitors is less than 10%. And there's lots of hurdles to get to the standard of care. And I would argue that there's a moral imperative here to get to triple therapy for DKD, right? You need to start with ACEs and ARBs, SGLT2 inhibitors, and perhaps MRAs in this particular patient. But there's a lot of hurdles to get through. So first, you need to identify CKD. You need to educate patients on CKD, potentially educate patients on new treatment, prescribe medications, and prior authorizations are the bane of all of our lives, and monitor for side effects, right? So, as mentioned earlier, only 8% of patients with type 2 diabetes or diabetic kidney disease patients get on SGLT2. So what percentage of clinicians would be able to push these medications and get patients optimized on max dose ACEs and ARBs, SGLT2, and non-steroidal MRA? So let's spend a little bit of time on the current standard of care for diagnosing and for risk stratifying CKD, right? So UACR, urinary albumin creatinine ratio, it's been there since the last 30, 40 years. It's underutilized, but it's necessary for diagnosis and classification of CKD, and it's part of guidelines and for HEDIS measures, right? Now, important thing to remember is nearly 50% of patients with CKD do not get urine albumin testing. Now, eGFR and CKD has led to this KDIGO heat map in which you can sort of divide this up into a grid based upon your UACR or albuminuria level. A1 is normal to mildly increased, A2 is moderately increased, A3 severely increased, and decreasing GFR going from G1 to G5. So obviously, lowest risk is this group, and highest risk is this group when you have low GFR and high UACR. But the problem is standard of care metrics do not UACR and GFR are not accurate for assessing risk, right? So there's a high biological variability of UACR and eGFR. Even within individuals, UACR on the same day, for example, depending upon a time when you take a UACR measurements vary from going down by 55% to going up by 125%. eGFR measurements vary from going down by 16% to up by 20%. eGFR poorly reflects underlying kidney damage, right? So if you take a biopsy and see how much fibrosis you have, patients who have normal GFR can actually have now no fibrosis or 100% fibrosis, and it varies very, very significantly. And hyperfiltration often precedes TKD progression, right? So there's a period of time before progression, which your GFR may be normal or increased, and it masks the actual disease process. It's normal to have some age-related decline in kidney failure, in kidney function. However, eGFR does not reflect when the drop is clinically significant. And the drop is not clinically significant. It can cause unnecessary stress for the patient and utilization of resources. For example, patients who need an NSAID for pain control, right? The question is, if you have a normal kidney function decline based on age, and this is not part of the underlying disease process, then should you give medications, or should you let people be in pain? And finally, most kidney protective drugs, be it a RAS inhibitor or be it an SGLT2 inhibitor, causes decreases in eGFR, and this is sort of expected because it decreases the interglomerular pressure. And so if you decrease, if you drop eGFR, this can be actually misunderstood and cause unnecessary alarm in which patients drop this important protective medication. So this is what I was talking about earlier, right? Even with a normal GFR, you can have no fibrosis on a biopsy, or you can have significant fibrosis on a biopsy. And there's a huge range in which the GFR is not picking up the underlying kidney damage. And determining who will progress is key. However, future trajectories of kidney function in early DKD vary and are very complex, right? Classically in medical textbooks, I was taught that first you have normal GFR and you progress, albuminuria increases, and then your kidney function sort of falls off a cliff. But data-driven ways have shown us that that's not the only way in which patients progress, right? There are patients that have decrease in albuminuria because of treatment or just stochastically. There are patients that can go from normal GFR to kidney failure without going through any of those albuminuria categories. There are patients that had no albuminuria but still progress on to kidney failure without having any increase in albuminuria. So, the point of the slide is that diabetic kidney disease is an extremely variable disease and has various trajectories that are very, very difficult to predict, and thus impedes clinical care. And the rise of electronic health records has sort of led to a number of sort of data points in that as busy clinicians, we have to integrate, right? So there's a lot of information present in the EGF in the electronic health record, including lab values, including new diagnosis, radiology results, vital signs, and we'll talk about the novel biomarkers in a bit. But the question is, how do you integrate all of these inputs and come up with a solution and come up with a good risk stratification tool for our patients who really need it with early stage diabetic kidney disease. So in the next part of the slide talk, I'm going to talk about a product that was invented at Mount Sinai, where there is I hope I'll convince you that there's an improvement on risk stratification with kidney intellects compared to eGFR and UACR, which is the current standard. And we move on from diagnosis to bioprognosis, right? Well, eGFR and UACR can identify what CKD stage you are in, KDIGO in this case. It might not tell you what the future of a patient is, right? And if the patient's going to progress on to a progressive kidney decline. But they are very useful and they've been used for many, many years. So in addition to eGFR and UACR, Kidney Intellects actually uses data from both eGFR and UACR, but also electronic feature, clinical feature in the electronic health record, and 3 prognostic biomarkers. And combining all of this information, the novel biomarkers, eGFR, UACR, and other clinical features in the electronic health record, it provides a more complete picture. So there are new biomarkers of subclinical inflammation and kidney injury. This allows for early prediction of DKD progression. So 3 biomarkers: tumor necrosis factor receptor 1, 2, and KIM1. So TNFR1 is a transmembrane protein that's mainly expressed on all cell types. In the kidney, it's predominantly in the glomerular and tubular epithelial cells. Its activation causes cell death. It binds the inflammatory cytokine TNF-alpha, and it's been strongly associated with progression of CKD in over 24 studies till date. TNFR2 is a transmembrane protein. Its expression is usually restricted to immune and endothelial cells. It has a significant correlation with TNFR1, and its activation triggers pro-inflammatory and pro-fibrotic pathways. And it's also associated with development and progression of CKD in over 24 studies. And kidney injury molecule 1 is present in kidney tubular cells. It's either shed into urine or leaks back into the serum with kidney injury, and its elevations are again prognostic for CKD progression. So there's a new emerging paradigm for how these biomarkers can aid in prediction of progressive diabetic kidney disease, right? So suppose you have diabetes, and diabetes is a very pro-inflammatory state because of hyperglycemia, insulin resistance, obesity, advanced glycation end products, which we're not going to talk about today, hypertension. That basically increases inflammation using TNFR1, 2, and potentially another biomarker called as SUPA, that causes tubular injury, and that leads to overt kidney disease, right? So the argument is whether biomarkers, because this is happening much earlier in kidney in the disease process, as opposed to the later stages when eGFR and UACR come in, can this allow for much earlier prediction of progressive CKD or ESRD? And these biomarkers are important because TNFR, tumor necrosis factor, is present at the center of this. So this is a kidney function correlating graph on network, and this shows the pathways which are most important for kidney function deterioration, and TNFR is at the center of this pathway, right? So I don't want to go down a rabbit hole of biology with this slide, but basically TNFR is integral in several of the disease processes in the kidney, and so is TNFR2. So this was the first paper, now, I don't know, like 10 years back, which showed TNFR1 and TNFR2 levels strongly predicted ESKD in patients with type 2 diabetes and Joslin kidney study. So if you look at the hazard ratio, in patients who did not have proteinuria, every standard deviation of TNFR1 was associated with 7-fold increase in the progression to ESKD. In TNFR2, almost 4-fold increase. In patients who had proteinuria, it was very, very similar. Then TNFR1 and 2 have also come across in unbiased studies of circulating proteins for kidney disease, right? So TNFR1 and 2 sort of, this is a study from, again, Krolewski's group at Joslin Clinic. They measured 194 proteins in like 1,000 patients, and the molecule that came up at the top again were TNFR1 and TNFR2. And TNFR1 reliably stratifies for risk of progression in multiple cohorts. There have been over 20 to date. This was a slide presented at ADA 2002 by Monica, and she showed that in over thousands of patients till date, TNFR1 and 2 have been reliably stratified, have been reliable biomarkers that stratify risk of progression. And kidney molecular injury 1 is also a marker of tubular injury. This is the kidney membrane. And when there's injury, the ectodermin of this goes into the urine, as well as backflow enters into the circulation. And an early study showed that TNFR, KIM1 was also strongly predictive. This was developed by Joe Monventry at Brigham Hospital. So many recent studies show that a multiplex of TNFR1, 2, and KIM1 are associated with kidney outcomes in various DKD cohorts, as well as Steve Coker did a meta-analysis recently which showed that this was the most studied and the strongest biomarkers to date, right? So the axis here shows the number of studies in which the biomarkers have been studied, and the axis here shows the pooled relative risk, and this finds that KIM1, TNFR1, and TNFR2 are those biomarkers which have the most studies and have the strongest relative risk of all of the other biomarkers. So Kidney Intellects helps translates all of this research findings into clinical actions, right? So it starts off with a blood test which combines 3 prognostic biomarkers, TNFR1, 2, and KIM1, and 7 data features which include eGFR and UACR. This information is combined through a machine learning algorithm to generate a patient-specific risk score and a patient-specific risk category. This identifies patients in the early stages 1 to 3B of chronic kidney disease, who are at low, intermediate, or high risk of progressive decline in kidney function. And in addition to the risk score, each report comes up with a guideline recommended clinical action plan. And this allows physicians, predominantly PCPs, to identify risk early enough to improve kidney outcomes and promote kidney health. So we conducted a validation study for kidney intellects. So the objective of the study was to assess whether a machine learned predictive model using novel biomarkers and electronic health record data compared with traditional models and metrics in patients with DKD stages 1 to 3 for predicting a progressive decline in kidney function. This was a pivotal study conducted to date in one of the largest biomarker studies conducted of its kind. So patients were 21 to 80 years of age with type 2 diabetes. The eGFR was 30 to 59 or eGFR of more than 60 with UACR of more than 30. We had 146 patients. The comparison was kidney intellects versus traditional methods. We used banked plasma from the biobank to measure the biomarkers, clinical variables from the EHR, and the model used a random forest model. And the composite outcome was either a sustained decline of eGFR of more than 40% of baseline or kidney failure, or a slope of more than 5 ml per year. And I'll use this in the future slides. So just remember that these were the eGFR and UACR inclusion criteria, and 21% of patients experienced the event within 5 years over a median follow-up of 4.3 years. And we used over 100 features. We considered over 100 features and for inclusion. And out of that, KIM1, TNFR1, baseline eGFR and baseline UACR were the most important feature. This is what's called a SHAP plot, which is explainability plot for a machine learning model. The axis shows basically the impact on the model output, and the color basically shows whether a high value or a low value contributes to output, right? For example, just looking at here, a high TNFR1 value pushes the model towards making a positive prediction of outcome. And this is the relative importance of the features. Again, KIM1, TNFR, TNFR1, TNFR2 are all important features in the final model. So in summary, kidney intellects bio-prognostic integrates in vitro diagnostics of TNFR1, 2, and KIM1, and key clinical factors to produce a patient-specific risk score and risk category for progression. And instead of just a unidimensional view, it provides you sort of a multidimensional and a holistic view of each individual patients, right? So TNFR1 and 2 are biomarkers, which are markers of injury and inflammation. KIM1 is a direct measure of kidney tubular injury. It includes serum calcium, which is indicative of mineral metabolism, AST levels, which also brings in a liver function. So instead of just having a single view of a patient, you can have a more holistic view for bioprognosis. And patients who are, these are the results. So patients who have said to be a high risk for kidney disease actually have 15-fold more likely to progress, to experience kidney function decline or kidney failure, as opposed to patients who are at low risk. So how does it compare to KDIGO, right? So the KDIGO yellow, as shown earlier, this includes patients who are in this KDIGO risk criteria, right? So KDIGO yellow, 51% of DKD 1 to 3 has, and it's a population with only 18% of the events. But you can further risk stratify this into low risk, intermediate risk, and high risk. In the low risk, the event rate is like 9%, which is twofold lower than the population event rate. And the high risk, the event rate is 56%. So more than 1 in 2 patients has the event, and it's threefold higher than the risk population. KDIGO orange, which is 32% of the patients with diabetic kidney disease 1 to 2, and it's a population of 22% of the events. If you look at kidney intellects, again, 42% are in the low risk group, 22% are in the high risk group. The low risk group has a 2.5 times lower event rate than the population average, and the high risk group has a almost threefold event rate than the high risk average. And KDIGO, the red group, which is the high risk group, it's a population with further than the events, with 40% of the events. Again, you can further risk stratify this further, right? There's 15% in this quote unquote high risk group that have a very low event rate, and a 42% which has almost a 75% event rate. So one of the key measures here is that kidney intellects demonstrated further risk stratification within this broad categories of KDIGO, right? And this is let's look at a comparison of standard of care. So patients who get scored as high risk by KDIGO, 36% of patients by just UACR and eGFR, but 73% of patients get scored as high risk by kidney intellects, including all of these different multi-dimensional views. And kidney intellects basically doubles the proportion of future ESKD patients high risk. So you identify more than 2 times of patients that have been flagged, that would have been missed by standard metrics of eGFR and UACR, and who reach dialysis. So it will miss the majority of type 2 diabetes patients who reach dialysis. And this is further validation of our work. So Canvas was which showed that Canvas was a clinical trial for SGLT2 inhibitors, which included patients with stage 1 to 3B at baseline. Again, adjusted hazard ratio for high versus low risk was 10-fold without adjustment. But if you adjust for age, sex, etc., right, you still get a 2-fold increment of risk versus increment of risk enrichment versus in high versus low risk. And the composite event rate was in canagliflozin versus placebo in Canvas, was actually lower in the Cana arm. And there was a 20 to 24% relative risk reduction on the starter, with an absolute risk reduction of 4, 5, and 11%. So it can actually identify patients in the high risk group who would benefit from canagliflozin treatment. So there's an increasing body of evidence for kidney intellect since 2020. The first paper was in August of 2020, which showed that in 2 patient cohorts, kidney intellects actually accurately predicted risk of kidney function decline than a validated clinical model. Then we had a primary paper in Diabetologia, which showed improved prediction of kidney outcomes over standard of care. We did health economic studies, which showed that kidney intellects risk assessment can yield significant benefits for patients with type 2 diabetes or kidney disease. There was a clinical proteomics papers, which was analytical validation of these biomarkers. The Canvas paper that I just presented was shown that this successfully risk stratified a large multinational cohort for progression of DKD. There was presented results of the American Diabetes Association, which I'll go through in a minute. And then finally, a recent paper which showed that a national group of PCPs actually demonstrated awareness of this risk stratification in making rigorous and evidence-based decisions, and it's highly representative of real clinical care. So kidney intellects helps triage patients and allows patients and you to make informed decision. If a patient is low risk, you stratify into low, intermediate, and high risk, right? You can potentially be less aggressive. You can start with a standard dose ASAP, standard blood pressure control, and standard glucose control. If the patient is high risk, you can potentially be more aggressive and start guideline recommended therapies like SGLT2, GLP-1, and finerenone. And this is, I think, better than non-selective application of these therapies, which will result in excessive aggressive medication management in some patients, cost, and potentially more adverse events, and then risks would outweigh the benefits of the new drugs. But in this group of patients that are highest risk of progression, they should be managed most aggressively and start therapies to slow the progression of kidney disease, right? And implementation of this has the potential to improve the clinical management of DKD and enhance cost effectiveness. And that's the definition of personalized medicine, right? Right managed treatment for the right patient at the right time. So this is actually from the report, which is depending upon whether you are low, intermediate, or high risk. So if you're at low risk, then you need to monitor eGFR and UACR at least once annually. Intermediate risk, at least, you need to do it every 6 months, potentially titrate ACE and ARB to maximally tolerated dose. Consider SGLT2 or GLP-1 if SGLT2 is not tolerated, and consider non-steroidal MRA if clinically indicated. If it's high risk, then potentially refer to nephrology or monitor eGFR and UACR up to 3 times a year, and strongly consider the following therapies: SGLT2 or an MRA. So there is time to intervene and the early stages of kidney disease prior to the advanced disease, right? When there's normal function, mild loss of function, or moderate loss of function, here there's not much to be done except for plan for dialysis, but there's an opportunity here to shift the DKD care upstream. So early intervention might lead to better outcomes, right? And this has been shown that starting SGLT2 can actually decrease ESRD by 1.5 years, right? This is one of my favorite graphics, which shows that if you don't start potentially SGLT2, you lose GFR kidney function at the rate of 2 ml per year. But if you start SGLT2, you lose it you don't lose it at all. If you don't start SGLT2, you might lose kidney function at 5 ml per year. If you start it, you might lose it at like 2 ml per year, but that gives you an additional 15 years freedom from ESKD. A way to portray this is that, you can potentially slow down the progression of ESKD from a hare to a tortoise, and, give an additional 15 years for your patients without need to start dialysis. And this is one of the clinical utility of studies that we did for patients with end-stage with early-stage diabetic kidney disease. We had more than 1,100 patients in the Mount Sinai Health System from March to November 2021. And the risk, and we saw what actions were taken by physicians after test results. So the breakdown was high risk of around 13%, intermediate of 40%, and low risk of 46%. Kidney intellects was ordered by a high rate of primary care practitioners, 60%. Only around 17% of nephrologists ordered it, and the remaining were endocrinologists. Physicians were 7-fold more likely to prescribe guideline-based therapies for high-risk patients, 3-fold more likely to make a change in blood pressure management, and 3-fold more likely to refer to endocrinologists or diabetologists. And that thus, in patients who are like high risk by kidney intellects, they were more likely to start off with in patients who are high risk for kidney intellects, physicians are much more likely to initiate SGLT2I or GLP-1, 3-fold more likely to adjust an antihypertensive regimen, and 3-fold more likely to refer to specialists. And patients were were very comfortable with the kidney intellects testing. They were comfortable receiving phone calls from the kidney intellects team. 82% asked for educational materials. Most of them asked for educational materials on nutrition. And kidney intellects was thought to be very, very helpful in understanding kidney health. And these are sort of real world reactions from patients, right? Patients who are low risk were actually happy to hear about the fact that they were kidney health. Patients who were high risk, actually wanted to take measures to try to reduce their risks, right? And these are real world reactions from physicians, both medical directors or PCPs and nephrologists, which showed that kidney intellects could be a very, very useful tool for making sure that they're doing the best for patients and following guidelines, and helping them get patients on SGLT2 inhibitors. The fact that since it's a program, they thought it was a great program for the patients. And nephrologist also helps confirm that whether patients were at high or low dose. So this is very well taken up by physicians on this. So I hope in like the 45 minutes or 47 minutes I've been talking, I hope I convinced you that we need better risk stratification for patients with early stage diabetic kidney disease. There's an opportunity here to move the diabetic kidney disease paradigm upstream and to prevent getting to dialysis, especially with the advent of novel protective medications, including SGLT2 inhibitors and MRAs. And kidney intellects as a novel bioprognostic can help with some of this. So I think that was all I had. Please, I'm happy to take questions or comments now. Thank you for listening.
Excellent. Thanks so much for that. Apologies for the drilling going on outside this building here. Thank you for that great presentation. And certainly we've used a lot of kidney intellects here, and our own Leo Amoruso is the site PI for the newest project. So we're happy to participate in part of this. We'll open the floor for questions. You can enter them in the chat or unmute yourself and ask. While we're waiting, maybe I'll ask a question, which is just, as a primary care doc, it's often sometimes hard for me to know when the right moment is to refer somebody to a nephrologist, because so much of this is, get them on the right medicines, control their sugar, control their blood pressure. And yet at the same time, obviously, you don't want people to crash land in dialysis. I get that. So especially as this test is so algorithmic and there's so many clear expectations for what we need to do with patients with CKD3 or whatever.
Yeah.
How do we know when the right time is to refer someone to nephrology?
So I think that basically if patients are at high risk, then it's potentially a right time to refer someone to nephrology. If it's an intermediate risk or low risk, then unless you have a clinical judgment, then I think you need to use a clinical judgment in combination with like the holistic patient plan, right? Again, remember that if you start referring everyone to nephrology, you'll never get seen and the system will be overwhelmed. So this, what it does is it works as an adjunct to your clinical decision, supports a clinical decision. But this is an adjunct to your clinical decision. It shouldn't really replace your clinical judgment.
Thanks. Other questions, Manira?
Yeah, I have a question. Thank you so much, Dr. Nadkarni, for such a wonderful presentation. As Dr. Weissman said, a lot of us have utilized kidney intellects in the outpatient clinic, especially the residents. So this was a great opportunity for us to kind of get a firsthand look as to how it came about from, the creator. I guess my question kind of goes along with what Dr. Weissman was referring to, how do we incorporate, or do you see kidney intellects being incorporated into, our risk stratification for patients with CKD? Because currently we are utilizing eGFR and the urine albumin, and as you mentioned, both of those markers are maybe not as accurate when it comes to patients with fibrosis. So do you see in the next 5 to 10 years that it is going to become a standard of care, for the division of nephrology and internal medicine to risk stratify patients really nationally and not just within the Mount Sinai system?
Yeah, I hope so, obviously, for personal reasons, but also because it's the right thing to do. I do think that, there's going to be a tipping point in medicine where things move away from one size fits all to more personalized medicine, and I think the technologies that have been developed over the last many years be it genomics or biomarkers, are sort of leading us to that tipping point, right? Now, whether all of that gets done is triangulation between physician preferences, patient preferences, and whether someone pays for the test or not, right? So reimbursement and insurance coverage. But I don't think things are moving in that direction, and legislation and regulation is moving in that direction. So, not just for this, but for other sort of initiatives to make sure that, patients are not missed and there's no one size fits all. I think this is going to be important.
Thank you so much.
Dr. Chang, it looks like you unmuted maybe.
Yes, hi, thank you. Two questions. First one is with the recent advent of monoclonal antibody showing beneficial treatment for type 1, do you see if that may be applicable in the future for any subpopulation of type 2? Second question would be, do we have data showing additive benefits in using ACE, ARBs with SGLT2 inhibitors? And I guess 2A question would be, with the caution of eGFR of 30, below which we kind of be more cautious with the SGLT or ACE inhibitor. Do you recommend a trial for people, say, between 20 and 30, 25 and 30, and see how they tolerate, or would you not do that? Thank you.
Sure. So to answer your first question first, I think that it might be useful in certain subpopulations of type 2 diabetes, because I do believe that a small proportion, a variable proportion of type 2 diabetes is actually like mass type 1. So the question how much it is, I don't know, but I do think that genetic studies have shown that some of there's a huge genomic overlap between type 2 and type 1 diabetes. So I think it will be beneficial for type 2 diabetes. The second question, if I understand you correctly, is that SGLT2 inhibitors have shown benefit over and above ACE inhibitors. Most of the trials have had ACE inhibitors in both arms, like, whatever, 80%, which is more than like the standard real world experience. Only like 40% or 50% of patients who should be on are on ACE inhibitors, right? The third thing is newest trial that came out, EMPA-KIDNEY, that actually went out down as low as 30 for empagliflozin. Now, whether it works below that, I think, it definitely should, if not for the kidney benefit, at least for the cardiovascular and heart failure benefit of SGLT2 inhibitors. And there are trials now actually doing it in dialysis patients, not for the kidney benefit, of course, but for the cardiovascular and heart failure benefit. So I think that, there's enough evidence now to try SGLT2 inhibitors at various levels of kidney disease. But again, also remember that, the lower you go with kidney function, the higher the chance of complications with SGLT2 inhibitors. That's why I don't think it's going to be a one-size-fits approach for everyone.
Thank you.
All right, any final questions? It's a couple minutes before the hour. I don't see anybody else. Dr. Nadkarni, thank you so much for joining us as always. And we'll stay in touch.
Thank you. Thank you so much. Thank you.
Thank you so much, Dr.
Everybody.
Nadkarni. Bye, everyone. Thank you for joining. Thank you for those in person.